Hi, my name is Abhinav Sharma. I'm presenting for CVCT at the European Society of Cardiology Heart Failure Congress. I'm here with Dr. John Teerlink to discuss the results of the Relax-AHF-2 trial. Thank you very much for being with us here today. Dr. Teerlink, could you tell us a little bit about the background and rationale for the Relax-AHF-2 trial?
Sure. So, as you know, acute heart failure is a major international problem. And to date, we don't have any really successful therapies to treat acute heart failure. And so we tried to take a lesson from Mother Nature and looked at the role of relaxin in women who are pregnant. And so relaxin is present in all of us, but in the setting of pregnancy, it goes up dramatically, many orders of magnitude. And in that setting, it acts as a protective agent, remodifying the vasculature as well as improving renal function. So these are factors that we thought would be important in the setting of acute heart failure. And so a number of preclinical and then early clinical studies were done, which confirmed these potential beneficial effects. We went on to perform the Relax-AHF trial, which enrolled 1,161 patients with acute heart failure. And in this study, we saw that there was a significant improvement in dyspnea, as assessed by an area under the curve measurement. And that was driven largely by an improvement in worsening heart failure, in that in-hospital worsening heart failure within 5 days. And that was also associated with improvements in signs and symptoms of heart failure, as well as improvements in biomarkers. So there was a suggestion that that serelaxin was preventing end organ damage by reductions in troponin, improving decongestion by decreasing NT-proBNP, as well as improving renal function by improvements in cystatin C as well as creatinine. All of these changes were associated with a 37% improvement in survival, both in cardiovascular as well as all-cause. And so this was the kind of rationale for saying, okay, we need to confirm these results in a larger context. And that was why we began to investigate it in Relax-AHF-2.
And would you mind telling us a little bit about the patients that you enrolled in Relax-AHF-2 and some of the outcomes that you evaluated?
Sure. So the patients enrolled in Relax-AHF-2 were nearly identical to the patients in Relax-AHF because we were looking for a confirmatory trial. The patients had to have acute heart failure, had to be enrolled within 16 hours of presentation, had to have evidence of acute heart failure as indicated by congestion on a chest x-ray, elevated NT-proBNPs, and we looked for patients, because this is a vasodilator with, we presumed, renal protective effects, looked for patients who had normal to elevated systolic blood pressure. So these patients in Relax-AHF-2 had systolic blood pressures of 125 or above, as well as mild to moderate renal dysfunction. And so that combination, that targeted group of patients we felt would have the most likelihood to benefit from serelaxin.
And what were the overall results of the Relax-AHF-2 trial?
So Relax-AHF-2 had two independently powered endpoints. The first of the primary endpoints was cardiovascular death at 180 days, and this endpoint was not achieved by this trial. The previous improvement in cardiovascular mortality was not seen. The second primary endpoint was a worsening of heart failure within 5 days. And this endpoint also did not demonstrate an improvement in the setting of serelaxin treatment, though it was a, we'll say, close near miss in terms of a p-value of less than 0.10. So there was a suggestion that, in fact, in this setting there might have been an improvement with serelaxin, but certainly we were very disappointed to show that it really didn't confirm any of these primary endpoints. There are multiple secondary endpoints as well, such as all-cause mortality at 180 days, cardiovascular mortality with renal failure and heart failure within 180 days, and all of those were also not different from placebo. Also, the length of stay was not different between the two groups. So overall, it was entirely a neutral study. There was no evidence of harm. In fact, the adverse events and serious adverse events were identical between the placebo and the serelaxin-treated patients. So we confirmed the safety, but we're not able to confirm the efficacy overall in the overall trial.
Given the very encouraging preclinical and clinical studies and the first Relax-AHF trial, why do you think the results came out as they did right now?
We don't know, and so we've done a series of studies, and this is very late breaking, so you guys are getting really early in this trial report. We did do a subgroup analysis that was a pre-specified look at some of the demographic variables, and we did not see any consistent difference in treatment effect based on those subgroups. One of the interesting things we also looked at was there a similar response to serelaxin between the Relax-AHF and Relax-AHF-2. And in both studies, we saw very similar decreases in systolic blood pressure. So there didn't seem to be a difference there. In addition, the patient characteristics were very similar between Relax-AHF and Relax-AHF-2, with the only difference being a higher level of NT-proBNP in the Relax-AHF-2 trial, and that was by design because we had a higher entry criteria for that. We did perform a core lab sub-study. And this core lab sub-study was in approximately 1,052 patients, so about the same size as Relax-AHF. And in this core lab sub-study of selected sites, we were able to show that, in fact, serelaxin did have the same effects on biomarkers in terms of reducing troponin, significantly improving NT-proBNP, as well as improving cystatin C. So there were these very encouraging biomarker findings that we thought normally were associated with improvements in outcomes. So we went ahead and asked the question, well, what were the outcomes in just that group of core lab patients, recognizing that it's a subgroup analysis and also a post hoc evaluation. And in this setting, we saw a p-value around 0.5 in terms of cardiovascular death. So no difference, even though it was about 11% difference, or actually 14% difference, I think, in that regard. But in the worsening heart failure, there was actually a nominally statistically significant difference in terms of serelaxin providing early and continued improvement in the worsening heart failure event. So that's intriguing, and we will have to look more at the studies to try to figure out what those results mean.
Why do you think it's been so challenging to find therapies that work in the setting of acute heart failure? There have been so many negative trials. Another one, essentially, which is neutral. Do you have any thoughts on this?
Well, I think we're still learning, and we need to keep in mind that it took us decades to figure out how to do chronic heart failure trials. And I think it's going to take that long for us to figure out how to do good acute heart failure trials. We need to be able to define the entity more clearly. We need to find more targeted therapies for specific patient populations, because I do not think we'll be able to hit the one-size-fits-all approach to acute heart failure. And I think we also need to take a little bit more care in terms of our patient selection in these trials.
And so what are some of the next steps, and what does the future look like for acute heart failure?
Well, there are a number of agents that are still being investigated for acute heart failure. There's nitroxyl donors are still being developed for acute heart failure. Cardiac myosin activators, the omecamtiv mecarbil, is one option that improves cardiac function. That would be specifically for acute heart failure with reduced ejection fractions. There are multiple new directions that we're still going to pursue, but I think we need to take the lessons from Relax-AHF-2 and try to see whether we can apply them to our future programs as well.
Great. Well, Dr. Teerlink, thank you so much for your time. This is Abhinav Sharma from CVCT at the European Society of Cardiology Heart Failure Congress. Thank you for your attention.